In 2010, the Merseyside Diabetes Network undertook a piece of development work looking at the feasibility of developing and implementing a network-wide Hypo Pathway to address severe hypoglycaemia. Now, we knew we couldn't do this alone, and we wanted to do this in partnership. And I'm pleased and thank Diabetes UK and Sanofi for allowing us to come here today to present our findings. Just to put this into some context, as Mike's alluded to, the background in terms of partnership working for me as a network lead is that we have over 1 million patients within our network. This is a little map of our network area with a diabetes prevalence of just under 6%, but wide variation between practices within this network area. We were established in 2005, and at the time of this project we had 3 PCTs and 4 acute trusts. But since PCTs were clustered in the last 12 months, we now have 4 PCTs and 5 acute trusts. We have a very active clinical network and QiC board, and I'm also working with 11 clinical commissioning groups. So our drivers, there are a number of drivers to help us with this initiative. We know that hypoglycemia is associated with significant economic and personal cost, from loss of days of work, potential loss of driving licence, fear for both the patient and the carer. We had Diabetes Standard 7, which was about putting in place protocols to deal with emergencies, and we also had a QiC agenda to deal with. Nationally, ambulances had a target to reduce their numbers of patients conveyed to A&E or taken to A&E, and for NWAS, North West Ambulance Service, during 2010-11, they were fortunate to be involved in a SECC project for referral management. And since we developed this project, the Quality Standard 13, which states that any patient having a hypoglycemic event needing third-party intervention is referred on to a specialist team, came into being, and hopefully we can demonstrate that this pathway now addresses that standard. Therefore, our project aims were to improve patient experience, care and safety, to improve the management of diabetes at the point of contact, to improve communications liaison between all staff groups, and also to improve opportunities for engagement of education and support, not only for patients and carers, but also for health professionals. We also wanted to reduce A&E attendances and hospital admissions if feasible, but on the understanding that as clinicians, not all patients could or should be treated at home. So this is the sort of pieces of work that we undertook in partnership with our NWAS colleagues. We needed to identify what the problem was. So when we approached NWAS, we asked them would they give us some baseline data. So they were able to pull off baseline data for 999 calls for diabetes. We've since learned that coding for diabetes at ambulance levels are also the same issues that you are experiencing in secondary care. We did note the big rise in April 2009, and we wondered why that was, and were assured it wasn't just to do with collecting data, but it just gives you an example of the sort of things that you need to be asking your ambulance trusts about. They were also able to provide us with a breakdown of those calls within our 3 PCTs as to when the ambulance calls were received by the call handler. And you can see there's obviously some nighttime hypos, and there are peaks around meal times, which has implications for developing services as teams develop. One of the other things that they were able to provide us with for each of the PCTs was a 12-month worth of data around postcode hotspots, so we could start to understand if there were particular areas that were having high numbers of call-outs. So we approached this project in 3 phases. Once we'd identified all the and had the baseline data, we set together a steering group with key stakeholders. And those key stakeholders included the diabetes specialist nurses from the community diabetes teams within our network, the diabetes specialist nurses or the inpatient teams for our acute trusts, patients, advanced paramedics from NWAS, the governance lead from NWAS, and latterly Adrienne, as she came involved in the project as referral management lead. And one of the first processes that we did as a steering group was to review both the patient information leaflet that are given to patients from the ambulance staff and also the existing management pathway by the ambulance staff.